Good morning, everyone. I'm very proud and happy to announce Dr. Judith Owens, who's been a friend of Narcolepsy Network for a very long time. She's the director of Boston Medical Center and Boston Children's Hospital, and on the faculty of Harvard Medical School. And Judy is Dr. Owens is especially experienced and has a lot of children in her practice. So welcome, Dr. Owens, and enjoy.
Oops. No, I shouldn't wear high heels. Anyway, thank you so much for inviting me. This is a real honor to be the keynote speaker for this wonderful conference. I think that patient support and education groups are absolutely key for sleep disorders in particular, and this organization is really a role model for other similar kinds of groups, and you should all be very proud of yourselves to be involved with this organization. So I am a developmental behavioral pediatrician by training. I also have a fellowship training in child psychiatry. So I am come to sleep medicine from kind of that perspective. And so I wanted to explore for myself, as well as for all of you, what we know about behavioral, i.e. non-pharmacologic treatments for narcolepsy, and equally importantly, what do we need to know? Where does the field need to go? And I hope by the end of this talk, you'll feel inspired to support and promote research in this area, because I think it's really absolutely key. So I do have some disclosures. I have some research support and serve as a consultant to several pharmaceutical companies. So the objectives this morning are to describe potential behavioral treatment targets in patients with hypersomnia disorders, and I'll be focusing largely on narcolepsy, and with an emphasis on the pediatric population, as Eveline indicated. I'm the director of sleep medicine at Boston Children's Hospital, and so although we see patients up to age 22 or 23, my focus is on children and adolescents. I want to review some of the evidence supporting these behavioral treatment strategies in narcolepsy, and then to outline potential approaches to incorporating behavioral interventions into general treatment plans for patients with hypersomnia disorders. So we know very well, and you know far better than I do, that adult patients with hypersomnia disorders have more educational and behavioral issues. They have higher rates of depression and anxiety. They experience more occupational challenges. They're more prone to driving accidents. They're more likely to have car crashes compared to healthy subjects, although this may be mitigated somewhat by the impact of pharmacologic treatment. I just want to go through, and again, this is familiar territory to all of you, I'm sure, but what I've done is in italics, I've highlighted those areas of the different features of narcolepsy that may be amenable to behavioral interventions. So the excessive daytime sleepiness with inability to stay awake, irrepressible need for sleep, or unintended lapses into drowsiness, which particularly before the diagnosis is made can be confused with fatigue. But fatigue is different in that it doesn't result in excessive or inadvertent episodes of sleep. In our society, there's a negative perception of sleepiness and an increased need for sleep. People brag about how little sleep they get, how little sleep they need. And here you see Sleepy, the dwarf, which is kind of the caricature of sleepiness in our culture, unfortunately. So the goal of treatment should be to produce the fullest possible return of normal function across all different domains. And pharmacologic treatment is considered first line, but there are a number of limitations to its effectiveness. Cataplexy, we all know, are sudden episodes of transient loss of muscle tone, often triggered by strong emotions. Patients typically sense the onset of an episode, which may allow them to prevent more serious kinds of injuries in certain circumstances. Patients can have rare episodes to several episodes a week or a day. Children have a rather unique presentation of cataplexy in many cases that is characterized by abnormal movements like gait disturbances and what is called cataplectic facies, which is prominent facial involvement, muscle involvement, which results in drooping of the facial muscles, tongue protrusion, and even sometimes speech impediments as a result of that. And that can occur throughout the course of a day. So you can imagine being a 7-year-old who looks like they had a stroke to all intents and purposes, and what that does to one's self-esteem in terms of interacting with peers and social involvement. And again, pharmacologic treatment is considered first line, but there are limitations. Sleep paralysis, transient loss of muscle tone, inability to move during the episode. Patients may experience other unpleasant sensations during sleep paralysis outside of hypnagogic and hypnopompic hallucinations. Sometimes may need vigorous attempts at arousal to resolve the episode, but may be triggered by both stress and insufficient sleep. So here's another potential intervention point for behavioral treatment. And finally, hypnagogic and hypnopompic hallucinations, dreamlike imagery which can be visual or auditory or tactile. Multisensory, people describe this intruder or sense presence, that there's someone in their bedroom. Some patients describe feeling like someone's pressing on their chest or having difficulty breathing, or unusual out-of-body experiences that again may be exacerbated by stress. There's a little bit of evidence to suggest the supine, so sleeping on your back or reading in bed, may impact the frequency of these hallucinations. And some patients report the ability to manipulate the content of the hallucinations, which is another interesting possible intervention point. And I don't want to neglect those of you in the audience who have other hypersomnia disorders like idiopathic hypersomnia or Klein-Levin syndrome. I will tell you, though, that there is almost no literature, scientific literature, discussing the application of behavioral treatments, the efficacy of behavioral treatments in these other disorders. And that's another knowledge gap that we need to address. Now, when it comes to children, children and adolescents with narcolepsy are greater risk for attention and cognitive problems with attendant poor learning skills, poor attendance and academic failure, social functioning, as I mentioned a little bit earlier, with some 2/3 of children reporting social difficulties, and they may be less able or willing to participate in extracurricular activities as a result of their disorder. A large percentage of pediatric patients with narcolepsy report emotional difficulties, and some 25% report depression. In addition, young patients are more likely to experience physical comorbidities, including other sleep disorders, like sleep-disordered breathing, sleep apnea, precocious puberty, so the onset of the development of puberty at age 5 or 6. You can imagine what that's like for a young child experiencing that. And obesity is very common, particularly in prepubertal children with narcolepsy. Again, adding to the social and physical stigma of this. And so the overall toll of narcolepsy is clear when you compare their health-related quality of life and affects every aspect of their lives. A recent study showed that 100% of parents of children with narcolepsy were concerned about how their child could cope, completely understandably. And 2/3 were anxious about financial issues, medical costs involved in pharmacologic treatment. And caregivers expressed the need to have a place where they could share information and experiences and provide encouragement to help their children cope, and both informal and professionally led peer support. But reported that many of those needs and expectations were not being met. And that's why this organization and a conference like this is so incredibly valuable to these families who don't experience that kind of support in their home communities. Also important to recognize that pediatric narcolepsy is oftentimes characterized by a very abrupt onset of core symptoms. Oftentimes the symptoms do not develop over time in a gradual fashion, which means that there is this sudden loss of previously being healthy and functional. And there is this need for the child to understand that this excessive sleepiness, which they don't understand the cause of, is symptomatic of a lifelong disease. And this is a really hard thing for families and young patients to understand and accept. And I hope that in my lifetime that will no longer be true, that there will be a cure for this disease, but right now there isn't. And so these kids are consigned to having this disorder, which requires daily management, as far as they know, for the rest of their lives. And this just illustrates, this is data from a narcolepsy repository in France, in which they've been collecting clinical data for quite some time, and you can see that many of these children have cataplexy, 80%, almost half with hallucinations, 25% with sleep paralysis, and parasomnias like sleepwalking, for example, are very common in these kids as well, which can pose safety risks in addition to the cataplexy. So I want to give you some real-world examples from patients that I have seen in my own practice that pose some interesting dilemmas that provide a target for behavioral intervention. So number one is the sophisticated student. This is a 17-year-old girl who was diagnosed with narcolepsy and cataplexy at age 13, possibly following an HPV vaccine, had been previously treated abroad where medications were more available. She's a high achiever, all honors classes, she's on several medications, and she asked, when she was living in Europe, everybody had wine with dinner. So she asked me as her physician, could she have wine with dinner while she was on sodium oxybate? She also had plans to become sexually active. And she was applying to college, so she wondered about the logistics of getting a highly controlled substance to her college, mailed to her college. So, just to know, alcohol is contraindicated in patients who are using Xyrem. And the company that makes Xyrem recommends complete abstinence from alcohol. And in terms of Provigil, the warning is you also should avoid drinking alcohol. It's not known how it will affect you taking Provigil. So what should I have told her? We can leave that for the Q&A. Not on my watch. This was a quote from the mom who accompanied this young lady. She was 21 years old for her first visit to me. She was diagnosed with narcolepsy and cataplexy 6 months ago. It started on armodafinil. She had severe daily cataplexy, and sodium oxybate was added in September of 2013. I had a discussion with this young lady about the fact that armodafinil can decrease the efficacy of oral contraceptives, because she was, just to let her know, and Mom said, well, it doesn't really matter because she's not sexually active and this isn't going to happen on my watch. Well, she came in for her next visit and we confirmed a pregnancy. So, if you read the label of Provigil, hormonal birth control methods may not work while you're taking it. There's also no adequate and well-controlled studies of armodafinil in pregnant women. And Xyrem, based on animal data, it may cause fetal harm and should only be used during pregnancy if the potential benefit justifies the potential risk. So again, we were faced with the real dilemma here about whether to continue medication in this patient. I will tell you the end of the story. For whatever reason, her narcolepsy and cataplexy improved dramatically when she was pregnant, and she actually didn't need to be on medication. But we got lucky that time. This is the athlete, 17-year-old high school senior, diagnosed with type 1 narcolepsy, on oros methylphenidate, which is like a Ritalin-like drug, and sodium oxybate. Significant daytime sleepiness, profound sleep inertia after scheduled naps. He wanted to get a driver's license, and he was applying to college hoping to get a football scholarship. Had already had 2 concussions. Well, the NCAA bans performance-enhancing drugs such as stimulants to protect student-athlete health and safety and ensure a level playing field. So, in order for a student-athlete to be granted a medical exception for this, they have to fulfill certain conditions. And as much as I was enthusiastic about this young man's ambitions to become a pro football player, what is the impact of having sustained 2 concussions already? And of course, the likelihood of having more of those in a patient who already has a central nervous system disorder poses a little bit of an ethical dilemma. Next case, a 13-year-old girl with a 6-month history of excessive daytime sleepiness following a vaccine. She was diagnosed with depression. Her multiple sleep latency test was not conclusive to narcolepsy, and because she had a sleep onset REM period, only 1 nap, even though she had a very short mean sleep onset latency. We trialed stimulants. She had a lot of side effects. She falls asleep at 11, but she has to get up at 5:30 because her high school starts at 7 a.m. And furthermore, she can't get special ed services because she doesn't have a diagnosis of narcolepsy yet. So this brings up the issue about how school personnel need to be educated about hypersomnia disorders. And of course, there are confidentiality issues there, and there's a social stigma of having a hypersomnia disorder. But very few educators, in my experience, including school nurses, have any experience with this. And so we need to educate them and bring them up to speed about what a student with narcolepsy is really undergoing. Because this issue of eligibility for special education services, accommodations in terms of timing of tests, reduced homework assignments, et cetera, is critical for academic success. Nap opportunities. I have many schools which say, well, you know what, he can just go to the back of the room and put his head down on a desk. No, that's not okay. On the other hand, a 7-year-old doesn't want to go to the nurse's office to take a nap because he thinks that makes him seem like a baby. So that's a real deterrent. The other problem is all teenagers in high school are sleepy. And how do you distinguish between a patient with narcolepsy and one who's getting 5 or 6 hours of sleep on a routine basis. So that brings up one of my favorite subjects, which I spend a lot of time going around the country talking about, is healthy school start times for middle and high school students, which are absolutely critical for patients with narcolepsy, but is very, very, very important for the health, safety, and well-being of all of our students. 8:30 or later. That's what the American Academy, yeah! That's what the American Academy of Pediatrics, the world's leading advocate for children's health, recommends. And I was fortunate enough to be the lead author on that policy statement. So go out in your communities and work for that, please. And then, college preparation and career counseling. Many of my patients have chosen higher level academic institutions which have more accommodations for students with learning problems, which they have found in many cases very helpful. So here's another case, an 18-year-old college freshman diagnosed with type 1 narcolepsy at age 16, has failed multiple medication trials, so now refuses to take any medication. He obtained his driver's license while he was on medication, and he wants to be able to continue to drive, even though he's now off. He says his excessive daytime sleepiness is under control, and he denies having cataplexy. But on objective tests, his mean sleep onset latency on his MSLT was 6.2 minutes, and he had 3 out of 5 sleep onset REM periods. So do I ethically allow this young man to continue to drive? And we'll talk about that more in a little bit. So hold on. So when we're talking about behavioral therapy, what do we mean? Strategic napping, extending nighttime sleep, what's called sleep hygiene, which are things like going to bed and getting it up at the same time, having a regular bedtime routine, not drinking caffeine during the day. Nutrition, I'll touch on that in a little bit. Physical activity, caffeine or not, nicotine or not. Adherence to medication strategies. How do you help patients be more compliant with taking their medications, and driving strategies? So examples of that would be something like systematic desensitization for cataplexy. So trying to find ways where patients can prevent themselves from having a cataplexy attack if they're able to identify triggers. There's something called imagery rehearsal therapy for sleep paralysis and hallucinations. Avoidance of environmental or social situations which may exacerbate symptoms. But think of it. I mean, I have kids in my practice who avoid hanging out with their friends because they're going to make them laugh, and they'll have cataplexy. And that is one of the saddest things that, as a physician, I can hear my patients talk about. Muscle relaxation, yoga, mindfulness, which is kind of this new, I think, very exciting area, which intentionally brings awareness to thoughts or sensations with an attitude of acceptance, patience, openness, curiosity, kindness, which is formally practiced through meditation, focused on purposely directing one's attention towards the breath, body sensations, feelings, or thought. This is a concept that has really infiltrated a lot of psychological therapies, and of course psychotherapy and support groups. So, what do we know about manipulating sleep, either scheduled naps or extending nighttime sleep? So this first study found that extending nighttime sleep, total sleep time of 595 minutes versus 417, resulted in a significantly prolonged sleep onset latency when measured by an MSLT, multiple sleep latency test, but didn't really improve sleep quality. There are a couple of studies which suggest that longer naps, like a 3-hour nap, for example, may be beneficial in reducing performance impairments, particularly compared to shorter naps, like 15 minutes, but that the benefits were also short-lived. so had dissipated within 3 hours after the nap. Other studies have looked at programs of regular napping, improving sleep onset latency, time to fall asleep. Again, this is when your sleep onset latency is a measure of sleep pressure on the multiple sleep latency test. Another study showed, this one was one of the few which showed that a short nap late in the afternoon seemed to improve sleepiness. But the final study showed that the addition of 2 15-minute naps during the day did not alter symptom severity or prevent unscheduled falling asleep during the day. So what we don't know is the optimal length, timing, number, and frequency of naps. What is the combined impact of extending your nighttime sleep and napping during the day? What's the combined impact of medication and sleep manipulation? And how does napping affect different outcomes? So napping may improve cognitive function, but does it improve mood regulation, for example? And then the important role of sleep inertia, which many patients find very troubling, because when they wake up from their nap, they have that groggy, just sort of confused, awful feeling that can last 10, 15, 20 minutes after waking from a nap. Nutrition and exercise. We don't know very much about this. We know that patients with narcolepsy tend to eat more frequently, and there may be this phenomenon called post-meal deactivation, where before a meal, patients report decreased napping and decreased sleepiness, but following the meal, increased sleepiness and napping. These other two studies are animal studies. So this was dogs on a treadmill. This is kind of an interesting study when you think about it. So when these dogs are on a treadmill, that did not increase their cerebrospinal fluid hypercretin or orexin. But when they played in a yard, it did increase it. Interesting. And this final one is orexin knockout. So these are mice that have the gene to produce orexin missing. Were significantly less likely than normal mice to, due to sleepiness, was for imminent cataplexy or reduced motivation to run. So in this study, running on a treadmill or a wheel increased wakefulness, but it also increased cataplexy. So what is the impact of timing, frequency, calorie content, composition of meals on daytime sleepiness and performance? We also need to understand how we can intervene with young kids who develop obesity to reduce weight gain. What is the impact of different intensity, duration, frequency, timing, et cetera, of physical activity on daytime sleepiness and performance, and on cataplexy as well? Are there differential effects, like in this mouse experiment, of physical activity on cataplexy versus sleepiness? Okay, what about cognitive behavioral strategies? So these are almost all single case studies. Okay, this is a report of 1 or 2 or 3 patients. Not the best evidence in the world. So single case studies suggest that hypnosis can reduce sleep attacks and sleep paralysis. There's a technique called lucid dreaming, which again, a single case study found improved sleep paralysis, hallucinations, and compliance with medication. Muscle relaxation, a single case, reduction in sleep attacks. And what's called cognitive behavioral therapy, which is the systematic application of the principles and learning techniques needed to evaluate and improve behavior. So one study found that problem solving under the guise of cognitive behavioral therapy improved drug adherence. Another study looked at timing of activities according to circadian predictable peaks and troughs of alertness and sleepiness throughout the day. And this last study looked at a structured program of psychosocial adjustment and found improvements in quality of life. But we don't know, we don't have any randomized controlled trials, the gold standard, where patients are randomized to either a treatment or control group of any of these techniques. And we don't know really anything, at least that I could find in the literature, about other kinds of strategies like yoga or Tai Chi, or the impact of social support groups. Driving strategies, the information out there is mixed. In some studies, what's called the maintenance of wakefulness test predicted driving impairment. And there are some researchers that feel that that's a good objective measure of daytime sleepiness. But when you ask sleep specialists, 77% said that untreated patients with narcolepsy should not drive, but 71% felt that driving should be allowed after successful treatment, however that's defined. So do you use the MWT to define that? Do you use the MSLT to define that? Do you use the patient's subjective report, like that young man I talked about earlier? What do you use? So we need to know what the best standard for fitness of driving is. This is different from state to state, and there should be a national standard for this. It's crazy that, you know, if you live in Maryland or you live in Virginia or you live in DC, there's different standards for this. We also need to understand it's not just sleepiness that impacts driving risk, it's cataplexy. In particular, what are optimal strategies for these young, inexperienced drivers on top of all the rest of this? So in 2015, the American Academy of Sleep Medicine published quality measures for the care of patients with narcolepsy. It included driving recommendations. And their take on this was that little is known about the effects of drug therapy on crash risk. But a diagnosis of narcolepsy is not on its own a sufficient reason to withdraw driving privileges, non-commercial. The determining factor should be an individual's driving ability, but how do you measure that? The presence or absence of cataplexy and the severity of sleep fragmentation. At present, there's insufficient evidence to support clinical and neuropsychological screening tests in assessing fitness to drive to prevent motor vehicle crashes. But they did mention that roadside naps, frequent breaks, and intake of coffee or other caffeinated beverages are useful recommendations. Does that apply to a high school student? I don't know. And then, you know, the bottom line is that you have to follow state laws, which are all over the place. So I want to spend a little bit of time talking about this survey study, which I think is a reflection of, hopefully, of what all of you out there are experiencing. So the goal of this study, and this is coming out in Behavioral Sleep Medicine, the journal, very soon. So the idea was to gather data on the need for cognitive and behavioral interventions, treatment targets, and patient acceptability. And this was an internet survey, and these happen to be members of Wake Up Narcolepsy, who are at least 17 years old. And they based their rationale on the fact that over half of treated narcoleptic subjects, this study suggested, reduced their dose of stimulant medications or had not taken any stimulants at all during a 24-hour monitoring period during which they were supposed to be on medication. And there were no significant differences whether you responded to stimulants or not, or age or gender or educational level. So what determines compliance? That's a really important question. And that studies in general suggest that combining education with behavioral management may be more effective than education alone. You can give people the knowledge, you know, taking your medication is good, not taking it is bad, but you also have to motivate them to do that. So this were 371 patients, most of whom were female and most of whom had narcolepsy. Symptoms of depression and anxiety endorsed by a huge percentage, and only 1% of patients with narcolepsy said they had never experienced mood or anxiety symptoms. Referrals to mental health specialists were common, reported by almost half of respondents, but they only rated the effectiveness of this as a 5 on a scale of 1 to 10. Respondents rated difficulties in work as an 8 out of 10, difficulties with family relationships, 7.3 out of 10, different social relationships, and many said that avoiding situations due to the symptoms of their disease resulted in significant difficulties in their lives. 83% used medication to manage symptoms. About 23% said that side effects had prevented them from using medication consistently, but overall medication effectiveness was rated as a 6 out of 10. So there's a big gap there. But this was the most interesting part to me. Over 90% said that they had used more than one non-pharmacologic strategy to manage symptoms. And only 3% said that they didn't use any non-pharmacologic strategies at all. So daytime naps were number 1, extended nocturnal sleep number 2, caffeine number 3, top 3 strategies. Followed by exercise, which we've seen, we have very little evidence to back up, diet, ditto, temperature manipulation, chewing gum. Unfortunately, nicotine was used as a strategy for combat daytime sleepiness, and mindfulness and yoga. And then there were a whole host of other strategies used by small percentages, energy drinks, poking yourself, flicking a rubber band on the wrist, eating ice, brainwave apps, cognitive training, massage therapy, etc. While these strategies were widely used, however, their perceived effectiveness was rated pretty poorly. So daytime napping got the highest rating, but it was still only a 4 out of 10. Scheduled sleep and diet manipulation, about the same. Caffeine, nicotine, and exercise, less than 4. And overall, patients with idiopathic hypersomnia consistently had lower effectiveness ratings for all of these strategies. Again, interesting and important, most patients learn these strategies from non-professional sources. 78% trial and error, 44% on the internet, 38% from other patients, 25% through patient-related organizations like yourself. Sad. Only 33% said that they were educated by their sleep specialist about behavioral interventions, and even smaller amount by their primary care physician. But moving forward, the vast majority expressed at least some interest in support groups, cognitive behavioral therapy, mindfulness and yoga. For example, 40% were extremely interested in cognitive behavioral therapy, 40% in mindfulness and yoga, 51% extremely interested in support groups. And those patients who did not express as much of an interest said they weren't sure they were effective, they didn't have the time, or they weren't satisfied with their current pharmacologic regimen. So, this may not be for everybody, but this data really suggests that there's a tremendous need out there. And 62% said they wanted a behavioral sleep medicine provider who had training in both mental health and sleep, because their mental health providers didn't know anything about sleep, and their sleep specialists didn't know anything about behavioral treatments. There's the rub. We've got to fix this. So the conclusions were, there's not really sufficient evidence base in the literature to continue to consider these strategies as an alternative to pharmacotherapy, but there is promise here. And that in particular, a behavioral sleep medicine trained specialist could really be of great help to these patients. And that we need to combine these interventions into a multi-component treatment package, similar to CBTI, cognitive behavioral therapy for insomnia, which is a well-developed, effective treatment. And in fact, the American College of Physicians came out with a statement this year saying that CBTI is the first-line treatment for patients with insomnia, not drugs. So I wonder if we could get there or close to there with narcolepsy. So here's where I'm going to get a little pie in the sky. We need to develop CBTN, so Comprehensive Multi-Component Cognitive Behavioral Therapy Program for narcolepsy patients, which would include psychoeducation, okay? Education and behavioral management interventions like goal setting and reinforcement to improve medication adherence. Behavioral techniques to improve nighttime sleep and daytime alertness, such as naps, extended sleep, dietary changes, exercise, relaxation strategies to more effectively manage cataplexy. Developing behavioral adaptations to improve hallucinations and fears of being alone. What is called cognitive restructuring. So the child who doesn't want to attend their best friend's birthday party because they're afraid they're going to have cataplexy. How do we help these kids kind of rework their anxiety and cognitive thoughts, maladaptive thoughts about this? Mentioned mindfulness earlier, assisting patients with development of age-appropriate social skills and development of coping strategies, particularly for the adolescents who are transitioning from being taken care of and watched over by their parents to becoming independent adults. So CBTN goals would be increased understanding of and insight into living with narcolepsy, adherence, we've mentioned many times, coping, reduction of distress, maintenance of gains, improved quality of life. That's what it all comes down to at the end of the day. And this is a little bit of a busy slide. And by the way, I'm happy to share this presentation with anybody because it's a lot of information. But these are some of the different techniques that could be incorporated into this treatment package, because it has to be multifactorial, multi-component in order to really successfully address. So there are challenges. So lack of public and healthcare provider awareness, certainly healthcare providers. We don't have enough trained behavioral sleep medicine providers. They exist in large cities and urban areas and academic centers, but there aren't enough of them out in the community. So what about alternative delivery systems? Online, there's been a huge progression in web-based insomnia treatments, CBTI. So why not use this technology to disseminate these? Insurance coverage, unfortunately, they may cover drugs, but they don't cover a lot of these behavioral interventions. But one practitioner survey, and this happened to be, this was in the United States, 63% had used behavioral strategies to reduce cataplexy and also for sleep attacks and excessive daytime sleepiness. And encouragingly, 32% of psychologists trained in CBTI are interested in applying it for narcolepsy, according to American Academy of Sleep Medicine survey in 2007. And in the UK, 15%, it's better than 0%, said they had used behavioral strategies either as an adjuvant or first-line treatment and found benefits. So there is some interest in this out there in the medical community. Just briefly, in terms of children, obviously social skills and play skills, really important, providing situations where children are less at risk to fall asleep, engaging the child in activities and games, where he can be awake and alert instead of sleepy and bored. Promote use of self-control strategies such as problem solving, how to interact with peers when being misunderstood, mocked, and bullied. Increase emotional awareness by labeling and verbalizing your feelings, recognizing sleepiness, and decreasing negative cognitive attributions. Encouraging the child to think positively about his disorder and discuss issues with the supportive adults and peers around them. So there is some data on cognitive behavioral therapy for narcolepsy, the components of which typically include extended sleep, nap training, cognitive restructuring, problem solving, systematic desensitization, and have found that you see improvements in quality of life and sometimes even in symptoms, excessive daytime sleepiness and cataplexy. But we need to understand what are the key core components of this multimodal treatment programs. What are the optimal formats and delivery vehicles? Do you need to have a face-to-face encounter with a provider in order for these strategies to be adopted and accepted as a patient? Or can you do it online? And what's the ideal length of treatment? And do we need to have boosters, along the way, 6 months later or a year later? Do you need to re-engage in a shorter, perhaps, program? So, the major research gaps. While pharmacologic treatment is considered first line, this may not resolve treatment. And studies suggest that less than 15% of patients with narcolepsy overall rely on medication alone. Up to half rely exclusively on behavioral strategies. And they're used for all the core features of narcolepsy. But overall, there are very few studies looking at these behavioral interventions. And we need to know more, understand more. I think that survey study that I went through in some detail was a very good beginning. But we need to hear from you about what you want, what is missing, how we can best provide it for you. So I would contend that in regards to behavioral interventions for hypersomnias, we don't just have a knowledge gap, we have a knowledge chasm. We need more research specifically targeting behavioral interventions for both adults and children, because clearly one size does not fit all age groups, does not necessarily fit gender, does not necessarily fit ethnicity, does not necessarily fit type 1 versus type 2 versus idiopathic hypersomnia, etc. But overall, while we're waiting for all this great research to be done, I think some of these common sense behavioral strategies, planned naps, healthy sleep habits, coping strategies, social support, need to be part of the treatment plan. And I want to give special thanks to my colleagues, some of them abroad, our pediatric sleep fellow, Dr. Akambaram, our sleep psychologist at Boston Children's, Eric Zhao, and I especially want to thank you for your attention.